Picture yourself standing in a mirror, looking at the shape of your body, the curve of your shoulders, the straightness of your spine, the length of your arms. Now imagine that beneath your skin, beneath the muscles and organs, there exists an intricate framework, a living architecture that has been sculpted over millions of years of evolution. This framework isn't static, isn't simply sitting there waiting. Right now, at this very moment, it's working, rebuilding itself, creating the very essence of your blood, storing minerals for future use, and protecting everything you hold most precious. Welcome to Bedtime Biology, where science meets serenity. Each night, we explore the quiet wonders of the natural world, calming your mind and sparking your curiosity. Please, like, subscribe, and comment below with where you're checking in from. Tonight, we're embarking on a journey through one of the most remarkable systems in your body. We're going to discover the skeleton, but not as you learned about it in school. We're going to understand it as it truly is, a living, breathing, constantly changing network of bones that tells the story of who you are, where you came from, and how your body performs miracles every single day without you ever noticing. This isn't just anatomy. This is the story of your bones, from the moment they first began to form before you were born, to this very second as you listen to these words. So settle in, let your breathing slow, and prepare to discover the hidden world within you. The world of bone. When you think of a bone, you might picture something dry and lifeless, like the skeleton hanging in a biology classroom, or the bones you see in museums. But that image couldn't be further from the truth. Your bones are among the most alive tissues in your entire body, teeming with activity, packed with cells that are constantly working, building, breaking down, and rebuilding. Let's begin by understanding what bone actually is. At its most fundamental level, bone is a composite material, a remarkable blend of organic and inorganic components that work together to create something that's simultaneously strong and flexible, rigid and dynamic. It's one of nature's most impressive engineering achievements, and it exists inside you right now. The composition of bone is actually quite elegant in its simplicity. Roughly 30% of bone tissue is organic material, primarily a protein called collagen. Collagen is the same protein that gives your skin its elasticity and your tendons their strength. In bone, collagen molecules are arranged in long, twisted strands, forming a fibrous matrix that provides the bone with flexibility and tensile strength. Think of collagen as the framework of a building, the steel beams that allow the structure to bend slightly without breaking. But collagen alone wouldn't be enough to support your body weight or protect your organs. This is where the inorganic component comes in. The remaining 70% of bone tissue is made up of minerals, primarily calcium and phosphorus, which combine to form a crystalline compound called hydroxyapatite. These microscopic crystals deposit themselves along and within the collagen fibers, hardening the matrix and giving bone its incredible compressive strength. If collagen is the steel framework, then hydroxyapatite is the concrete that fills in around it, creating a structure that can withstand tremendous pressure. This combination of organic flexibility and inorganic rigidity is what makes bone so remarkable. The collagen prevents the bone from being too brittle, while the minerals prevent it from being too soft. Together, they create a material that can support hundreds of pounds of weight while still having enough give to absorb shocks when you walk, run, or jump. It's a perfect balance, and your body maintains it with astonishing precision. But bone isn't just a solid mass of this composite material. If it were, your skeleton would be impossibly heavy and inflexible. Instead, bone tissue exists in two distinct forms, each serving a specific purpose. The first is called compact bone, also known as cortical bone. This is the dense, smooth outer shell that you see when you look at a bone. Compact bone accounts for about 80% of your skeletal mass. It's organized into functional units called osteons, which are cylindrical structures that run parallel to the length of the bone. Each osteon contains a central canal, called a Haversian canal, through which blood vessels and nerves pass. Surrounding this central canal are concentric layers of mineralized bone matrix, arranged like the rings of a tree. This layered structure gives compact bone its tremendous strength, while still allowing nutrients and oxygen to reach the living cells embedded within it. The second type of bone tissue is called trabecular bone, also known as spongy or cancellous bone. Despite its name, spongy bone isn't soft. It's still made of the same hard materials as compact bone. What makes it spongy is its structure. Instead of being solid, trabecular bone has a honeycomb-like appearance, with thin struts of bone called trabeculae forming an intricate lattice. This design is actually a masterclass in engineering efficiency. The spaces between the trabeculae make the bone lighter without significantly compromising its strength, and the lattice structure is arranged along the lines of mechanical stress, providing support exactly where it's needed most. Trabecular bone is found primarily at the ends of long bones and in the interior of flat bones like your ribs and skull. It's also the location of bone marrow, the soft tissue that produces your blood cells. We'll explore that remarkable process later, but for now, just understand that this spongy interior isn't wasted space. It's a crucial component of your skeleton's function. Now, deep within both types of bone tissue, embedded in the hardened matrix, are the living cells that make bone what it is. These cells are the workers, the architects, and the maintenance crew of your skeletal system, and they never rest. The most numerous cells in mature bone are called osteocytes. These are former osteoblasts, bone-building cells that became trapped in the matrix they created. Don't feel sorry for them though. This is their destiny, and from their embedded positions, they play a crucial role. Osteocytes have long, thin projections that extend through tiny channels in the bone matrix, connecting them to other osteocytes and to the blood supply. Through this network, they sense mechanical stress on the bone. When you exercise, when you walk, even when you simply stand up, your osteocytes detect the forces acting on your skeleton and send signals to other cells, telling them where bone needs to be strengthened or where it can be safely removed. Then there are the osteoblasts, the builders. These cells gather on bone surfaces and secrete osteoid, the organic matrix that will become new bone. Osteoblasts are essentially construction workers, laying down the framework and then overseeing the mineralization process as calcium and phosphorus crystals deposit themselves into the matrix. Osteoblasts respond to hormones, to mechanical stress, and to growth factors, ramping up their activity when your body needs more bone mass or when damage needs to be repaired. On the opposite side of the equation are the osteoclasts, the demolition crew. These are large, multinucleated cells that break down bone tissue. they attach themselves to bone surfaces and secrete acids and enzymes that dissolve both the mineral and organic components of the matrix. This might sound destructive, but it's absolutely essential. Old bone accumulates microscopic damage over time, and it needs to be removed and replaced with fresh, strong bone. Osteoclasts also help release calcium from your bones into your bloodstream when your body needs it for other functions, like nerve transmission and muscle contraction. The balance between osteoblast activity and osteoclast activity is what determines whether your bones are growing, staying the same, or losing mass. In children and adolescents, osteoblasts work faster than osteoclasts, resulting in net bone growth. In healthy adults, the two are roughly balanced, maintaining bone mass. In older adults, especially after menopause in women, osteoclast activity can outpace osteoblast activity, leading to bone loss. But we'll come back to that when we talk about bone diseases. There's one more crucial component of bone structure we need to understand: the periosteum. This is a thin, tough membrane that covers the outer surface of all bones, except where they're covered by cartilage at joints. The periosteum is packed with blood vessels and nerves, making it highly sensitive to pain. It's also the attachment point for tendons and ligaments. Most importantly, the periosteum contains osteoprogenitor cells, which are stem cells that can differentiate into osteoblasts when new bone needs to be formed. When you break a bone, the periosteum plays a crucial role in healing, generating new bone cells to bridge the gap. Understanding the composition and structure of bone helps us appreciate just how remarkable this tissue is. It's not a single, uniform material. It's a complex, hierarchical structure where every component, from the molecular level to the gross anatomy, is perfectly suited to its function. Your bones are strong enough to support your weight and protect your organs, light enough that you can move efficiently, and alive enough that they can respond to your body's ever-changing needs. And this is just the beginning. Because while all bones share these fundamental characteristics, the skeleton itself is an incredibly diverse structure, with bones of wildly different shapes and sizes, each one precisely designed for its specific role in your body. Let's take a step back now and look at the complete picture. The adult human skeleton contains 206 individual bones, though this number can vary slightly from person to person. Some individuals have extra vertebrae or ribs, while others may have bones that fused unusually. But 206 is the standard count, and these bones come in an astonishing variety of shapes and sizes. The smallest bone in your body is the stapes, one of 3 tiny bones in your middle ear. It's about 3 millimeters long, roughly the size of a grain of rice. The largest is the femur, your thigh bone, which in an average adult is about 19 inches long and can support more than 30 times your body weight. Between these extremes lie bones of every imaginable configuration, each one perfectly suited to its role. Anatomists divide the skeleton into 2 main parts: the axial skeleton and the appendicular skeleton. This division isn't arbitrary. It reflects both the developmental origins of the bones and their functional roles. The axial skeleton forms the central axis of your body, the core structure around which everything else is built. It consists of 80 bones and includes your skull, your vertebral column, your rib cage, and a few associated bones. The word axial comes from axis, and that's exactly what this part of your skeleton provides: a central support structure that protects your most vital organs and provides attachment points for muscles. Let's start at the top. Your skull contains 22 bones, though in adults, 21 of them are fused together into a single rigid structure. The only movable bone in your skull is your mandible, your lower jaw. The skull itself is divided into two parts: the cranium, which encases and protects your brain, and the facial skeleton, which forms the structure of your face. We'll explore the skull in much greater detail later, because it deserves its own section. Moving down, we come to the vertebral column, your spine. This is one of the most elegant structures in the entire human body. Your spine contains 24 individual vertebrae, plus 2 fused sections. The sacrum, made of 5 fused vertebrae, and the coccyx, or tailbone, made of 4 fused vertebrae. Each vertebra is a separate bone, and between them are cushioning pads of cartilage called intervertebral discs. This design allows your spine to flex and twist, while still providing stable support for your torso. The vertebrae aren't all identical. They're divided into 5 regions, each with its own specialized shape. At the top are 7 cervical vertebrae in your neck, the smallest and most delicate. The first cervical vertebra, called the atlas, is especially unique because it supports your skull and allows you to nod your head. The second, called the axis, has a peg-like projection that allows your head to rotate from side to side. Below the cervical spine are 12 thoracic vertebrae in your upper and mid-back. Each thoracic vertebra connects to a pair of ribs, forming your rib cage. Then come 5 large lumbar vertebrae in your lower back. These are the biggest vertebrae because they bear the most weight. Below them, as mentioned, are the fused vertebrae of the sacrum and coccyx. Your spine isn't straight, despite the way we often draw it. When viewed from the side, it has 4 curves: a forward curve in the cervical region, a backward curve in the thoracic region, another forward curve in the lumbar region, and a backward curve at the sacrum and coccyx. These curves aren't random. They're crucial for maintaining balance, absorbing shock, and allowing your trunk to move efficiently. A baby's spine doesn't have these curves at birth. They develop gradually as the child learns to hold up their head, sit, and walk. Attached to your thoracic vertebrae are your ribs, 12 pairs of them, 24 bones in total. Most people's ribs connect to their sternum, the flat bone in the center of your chest, via flexible strips of cartilage. The first 7 pairs of ribs, called true ribs, each have their own cartilage connection to the sternum. The next 3 pairs, called false ribs, connect to the sternum indirectly through a shared cartilage. The last 2 pairs, called floating ribs, don't connect to the sternum at all. They're anchored only to the vertebrae, leaving their front ends free. Your rib cage does more than just protect your heart and lungs, though that's certainly important. It also plays a crucial role in breathing. When you inhale, muscles between your ribs contract, pulling them upward and outward. This expands your chest cavity, creating negative pressure that draws air into your lungs. The flexibility of the cartilage connections allows this movement while still maintaining the protective structure of the cage. Completing the axial skeleton are a few smaller bones. The hyoid bone in your neck, which supports your tongue and doesn't attach to any other bone, and the tiny ear ossicles, 3 bones in each ear that transmit sound vibrations. These 6 ear bones, the malleus, incus, and stapes in each ear, are often counted separately from the main skeleton. which is why you'll sometimes see different total bone counts. Now let's turn to the appendicular skeleton, which consists of 126 bones. Appendicular comes from appendage, and this part of your skeleton includes all the bones of your limbs, along with the bones that connect your limbs to your axial skeleton. Starting at the top, you have your pectoral girdle, which connects your arms to your trunk. Each side of the pectoral girdle consists of two bones, the clavicle or collarbone, and the scapula or shoulder blade. Your clavicle is the only bony connection between your arm and your axial skeleton. It forms a joint with your sternum at one end and with your scapula at the other. Your scapula, meanwhile, is held in place mainly by muscles, allowing it to glide across the back of your ribcage. This arrangement gives your shoulder remarkable mobility, though it also makes it more prone to dislocation than more stable joints like your hip. Each of your upper limbs contains 30 bones. At the top is the humerus, the long bone of your upper arm. It forms a ball and socket joint with your scapula at your shoulder and a hinge joint with your forearm bones at your elbow. Your forearm contains two bones, the radius on the thumb side and the ulna on the pinky side. These bones can rotate around each other, allowing you to turn your palm up or down. Your wrist is a marvel of small bones. It contains 8 carpals arranged in 2 rows. These small, irregularly shaped bones slide against each other, giving your wrist its flexibility. Beyond the wrist are 5 metacarpals, the bones of your palm, and then 14 phalanges, the bones of your fingers. Your thumb has 2 phalanges, while each of your other fingers has 3. Moving to the lower body, you have your pelvic girdle, which connects your legs to your spine. Unlike your pectoral girdle, your pelvic girdle is designed for stability rather than mobility. It consists of the sacrum and coccyx from your spine, plus 2 hip bones, 1 on each side. Each hip bone is actually formed from 3 bones, the ilium, ischium, and pubis, which fuse together during adolescence. Your pelvis forms a bowl-shaped structure that supports your abdominal organs and bears the weight of your upper body. Each lower limb contains 30 bones. The femur, your thigh bone, is the longest and strongest bone in your body. It forms a ball and socket joint with your hip bone at the top and a complex hinge joint with your shin bone at your knee. Your kneecap, the patella, is actually a sesamoid bone, meaning it develops within a tendon. It protects the front of your knee joint and increases the leverage of your thigh muscles. Your lower leg contains 2 bones, the large, weight-bearing tibia or shin bone, and the thinner fibula on the outside. Your ankle contains 7 tarsals, similar in function to the carpals in your wrist, but much larger and stronger because they need to support your weight. The largest tarsal is the calcaneus, your heel bone. Beyond the ankle are 5 metatarsals in the sole of your foot and 14 phalanges in your toes, arranged just like in your fingers. This tour of the skeleton might seem like a simple catalogue of bones, but each one of these structures represents millions of years of evolutionary refinement. Your upper limbs are designed for manipulation and tool use, with joints that allow an incredible range of motion. Your lower limbs are designed for bipedal locomotion, with larger, stronger bones and more stable joints. Your axial skeleton protects your vital organs while allowing flexibility and movement. Nothing is random. Every bone, every curve, every joint exists for a reason. Understanding the skeleton as a whole helps us appreciate the next remarkable fact. This entire structure, all 206 bones, didn't exist when you were born. You came into the world with about 270 bones, mostly made of soft, flexible cartilage. The story of how those cartilaginous templates transformed into your adult skeleton is one of the most fascinating processes in human biology. Before you took your first breath, before you could see or hear or feel the world around you, your skeleton was already under construction. The process began just a few weeks after conception, and it continued, in some respects, well into your 20s. The transformation of cartilage into bone is called ossification, and it's one of the most carefully orchestrated processes in human development. Bone formation happens in two fundamentally different ways, and understanding both of them will help you appreciate the complexity of skeletal development. The first method is called intramembranous ossification. Intramembranous means within a membrane, and that's a fairly literal description of what happens. In this process, bone develops directly from sheets of embryonic connective tissue without any cartilage stage in between. This is how the flat bones of your skull, your collarbone, and your mandible form. It begins when mesenchymal cells, which are stem cells from embryonic tissue, gather together in the membrane and differentiate into osteoblasts. These newly formed osteoblasts begin secreting osteoid, the organic matrix of bone. As more osteoid is laid down, it starts to mineralize, hardening into actual bone tissue. The osteoblasts that get trapped in their own secretions transform into osteocytes, the mature bone cells we talked about earlier. Meanwhile, other mesenchymal cells in the area differentiate into blood vessels, ensuring the growing bone has an adequate blood supply. This process creates small centers of bone formation called ossification centers. From these centers, bone grows outward in all directions, like an island expanding across water. Eventually, multiple ossification centers merge, creating larger bones. The edges of these developing bones remain membrane covered for a while, creating the soft spots called fontanelles that you can feel on a newborn baby's head. These soft spots allow the skull to compress during birth and give the brain room to grow rapidly during infancy. They gradually close as bone formation continues, usually by the time the child is about 18 months old. The second method of bone formation is called endochondral ossification. Endochondral means within cartilage, and this is how most of your skeleton forms. Essentially, your body first creates a cartilage model of each bone, then systematically replaces that cartilage with actual bone tissue. This process is more complex than intramembranous ossification, but it's also more versatile, allowing bones to grow in length over many years. Endochondral ossification begins around the 6th to 8th week of embryonic development. Mesenchymal cells differentiate into chondroblasts, cells that produce cartilage, and these chondroblasts create a miniature cartilage version of the future bone. This cartilage model has roughly the right shape, but it's much smaller than the eventual adult bone will be, and it's soft and flexible. Soon after the cartilage model forms, a thin layer of bone begins to form around the middle of the shaft. This is created by osteoblasts in the membrane surrounding the cartilage. At the same time, the cartilage cells in the center of the shaft start to enlarge and die, creating cavities in the cartilage. Blood vessels invade these cavities, bringing osteoblasts with them. The osteoblasts begin laying down bone inside the cartilage model, replacing it from the inside out. This initial area of bone formation is called the primary ossification center, and it appears in the shaft, or diaphysis, of the bone. For the long bones in your body, like your femur or humerus, this primary ossification center forms before birth, during fetal development. By the time you're born, the shafts of your long bones are already made of bone, though the ends are still cartilage. After birth, secondary ossification centers appear at the ends of long bones, in the regions called the epiphyses. Blood vessels and osteoblasts invade the cartilage at each end, and bone begins to form there as well. But here's the crucial detail. Between the primary ossification center in the shaft and the secondary ossification centers at the ends, a layer of cartilage remains. This is called the epiphyseal plate, or growth plate, and it's the key to how bones grow longer. The growth plate is an extraordinary structure. It contains several distinct layers of cartilage cells, each at a different stage of development. At the end of the bone, farthest from the shaft, is a region where cartilage cells are relatively quiet. Below that is a proliferation zone, where cartilage cells are rapidly dividing, creating new cells that line up in columns. Further toward the shaft is a region where the cartilage cells enlarge dramatically. Finally, at the border between the growth plate and the bone shaft, the enlarged cartilage cells die, and the cartilage matrix around them calcifies. Osteoblasts then move in and replace this calcified cartilage with actual bone. This process creates a conveyor belt effect. New cartilage forms at the end of the bone, pushing the growth plate away from the shaft. Meanwhile, at the other end of the growth plate, cartilage is being replaced by bone, adding length to the shaft. The growth plate itself stays roughly the same thickness, but the bone grows longer on both sides of it. This continues throughout childhood and adolescence. The growth plates in different bones close at different times, but the general pattern is consistent. Growth plates in the hands and feet close first, usually in early adolescence. The growth plates in the long bones of the arms and legs close later, typically between ages 14 and 17. The last growth plates to close are usually those in the collarbones, which may not fully close until the mid-20s. Once a growth plate has completely ossified, that bone can no longer grow in length. This is why your height is essentially fixed by late adolescence. Even after growth plates close, bones can still change in other ways. They can become thicker through a process called appositional growth, where osteoblasts on the outer surface of the bone lay down new layers of compact bone. This is how bones strengthen in response to exercise and mechanical stress. Bones can also change their internal structure, remodeling themselves throughout life in response to the forces acting on them. The regulation of bone growth is incredibly complex, involving numerous hormones and growth factors. Growth hormone from the pituitary gland stimulates the proliferation of cartilage cells in the growth plates. Thyroid hormones are essential for normal bone development. Sex hormones, particularly estrogen, ultimately cause the growth plates to close, ending longitudinal growth. Vitamin D and parathyroid hormone regulate calcium levels, ensuring that mineralizing bone has adequate calcium and phosphorus available. What's truly remarkable is how precisely timed all of this is. Your body somehow knows to start the ossification process at exactly the right time for each bone, to maintain the growth plates through childhood and adolescence, and to close them at the appropriate age. The mechanisms underlying this timing are still not fully understood, but they involve complex interactions between your genes, your hormones, and environmental factors like nutrition and physical activity. When you look at a newborn baby, you're looking at a skeleton in transition. The baby has more bones than an adult because many bones that will eventually fuse are still separate. The skull bones are separated by soft fontanelles. The hip bone is still 3 separate bones. The vertebrae of the sacrum and coccyx haven't fused yet. Over the next 2 decades, these separate bones will gradually merge. The cartilage will be replaced by bone, and the growth plates will close, resulting in the adult skeleton of 206 bones. But even then, the skeleton isn't finished changing. As we'll see later, bone is constantly being remodeled throughout your life, adapting to the demands you place on it. Your skeleton at age 20 is different from your skeleton at 40, which is different from your skeleton at 70. The story of bone development doesn't end with growth. It continues in a different form for as long as you live. We've talked about the structure of bone, the organization of the skeleton, and how bones grow. Now, we need to turn our attention to one of bone's most crucial and least appreciated functions. Hidden inside your bones, in the soft tissue that fills the spaces within trabecular bone, is a factory unlike any other in your body. This is your bone marrow, and it's where your blood is born. Every single day, without you ever thinking about it or feeling it happen, your bone marrow produces about 200 billion red blood cells, 100 billion white blood cells, and 100 billion platelets. This isn't a one-time event. It's a continuous process that goes on every second of every day of your life, replacing old blood cells with fresh ones, maintaining the delicate balance that keeps you alive. To understand how remarkable this is, you need to understand what's actually being produced. Red blood cells carry oxygen from your lungs to every tissue in your body. Without them, your cells would suffocate in minutes. White blood cells are your immune system, defending you against bacteria, viruses, and other threats. Platelets are essential for blood clotting, sealing wounds, and preventing you from bleeding to death from minor injuries. Your body needs all of these cells in precisely the right quantities, and bone marrow is what makes that possible. Bone marrow comes in 2 types, red marrow and yellow marrow. Red marrow is the active, blood-producing tissue. It's red because it's packed with blood cells in various stages of development and has an extensive blood supply. Yellow marrow, on the other hand, is primarily composed of fat cells. It serves as an energy reserve and can convert back to red marrow if the body needs to increase blood cell production, such as after significant blood loss or during certain illnesses. In infants and young children, nearly all bone marrow is red marrow. It fills the cavities in bones throughout the body, from the long bones in the arms and legs to the flat bones of the skull and pelvis. But as you age, much of this red marrow gradually converts to yellow marrow. By adulthood, red marrow is primarily found in flat bones like the sternum, ribs, pelvis, skull, and vertebrae, and in the ends of long bones like the femur and humerus. The central shafts of long bones contain mostly yellow marrow by this point. The process of blood cell formation, called hematopoiesis, begins with hematopoietic stem cells. These are remarkable cells that have 2 defining characteristics. They can divide to create more stem cells, maintaining the stem cell population, and they can differentiate into any type of blood cell. It's this versatility that makes them so valuable. The journey from stem cell to mature blood cell is a branching path. A hematopoietic stem cell first becomes a progenitor cell, which is committed to becoming either a myeloid cell or a lymphoid cell, but hasn't yet specialized further. Myeloid progenitors will eventually become red blood cells, platelets, or certain types of white blood cells. Lymphoid progenitors will become other types of white blood cells, particularly the lymphocytes that are crucial for adaptive immunity. From there, the paths branch further. A cell destined to become a red blood cell goes through several stages of development, each with its own name: proerythroblast, basophilic erythroblast, polychromatic erythroblast, orthochromatic erythroblast, reticulocyte, and finally, mature erythrocyte. At each stage, the cell changes in size and appearance, gradually accumulating hemoglobin, the oxygen-carrying protein that gives red blood cells their color, and eventually ejecting its nucleus to make more room for hemoglobin. The development of white blood cells is equally complex, with different lineages producing different types of cells. Neutrophils, which are the most abundant white blood cells and serve as first responders to bacterial infections, develop through one series of stages. Monocytes, which leave the bloodstream and become macrophages that engulf and digest pathogens, develop through another. Lymphocytes, including the B cells that produce antibodies and the T cells that coordinate immune responses, follow yet another path. Platelets are produced in an unusual way. They're not actually whole cells, but fragments of very large cells called megakaryocytes. A megakaryocyte can be 10 to 15 times the diameter of a normal cell and contains a bizarre multilobed nucleus. As it matures, the megakaryocyte extends long projections into the blood vessels that run through the bone marrow. These projections fragment into thousands of tiny pieces, each of which becomes a platelet. The entire process of hematopoiesis happens within a highly organized microenvironment in the bone marrow called the hematopoietic niche. This niche contains not just the blood-forming cells themselves, but also stromal cells, which provide structural support, endothelial cells, which line the blood vessels, and various other support cells that secrete growth factors and cytokines. These signaling molecules regulate the production of blood cells, ramping up production when needed and slowing it down when adequate numbers have been produced. The timing of blood cell production is exquisitely controlled. Red blood cells live for about 120 days before they're removed from circulation by the spleen and liver. Your body monitors the oxygen-carrying capacity of your blood and adjusts red blood cell production accordingly. If you move to high altitude, where oxygen is scarce, your kidneys produce more of a hormone called erythropoietin, which stimulates the bone marrow to produce more red blood cells. Within days, your red blood cell count begins to rise. White blood cells have much shorter lifespans, ranging from hours to days, depending on the type. Neutrophils, for example, typically survive only about 5 to 8 hours once they leave the bone marrow. When you get an infection, your body can rapidly increase white blood cell production, sometimes doubling or tripling the output of certain types of cells within hours. Platelets survive for about 5 to 9 days. They're constantly being consumed as they perform their role in forming tiny clots throughout your body, sealing microscopic tears in blood vessels that you never even know occurred. If you have a major injury and lose a lot of blood, your bone marrow can ramp up platelet production to replace what was lost. The bone marrow is also a crucial site for the development and storage of immune cells. Certain types of lymphocytes remain in the bone marrow after they mature, creating a reservoir of immune memory. Other immune cells return to the bone marrow after circulating through the body, finding safe havens where they can rest and survive for extended periods. This makes the bone marrow not just a factory, but also a warehouse and sanctuary for immune cells. One of the most profound medical applications of our understanding of bone marrow is the bone marrow transplant. In certain diseases, particularly blood cancers like leukemia and lymphoma, the bone marrow becomes diseased and produces abnormal cells. In some cases, the treatment involves high doses of chemotherapy or radiation to destroy the diseased marrow, followed by transplantation of healthy marrow from a donor. The donor's hematopoietic stem cells are extracted from their marrow, or more commonly today, mobilized into their bloodstream and collected. These stem cells are then infused into the patient's bloodstream, and they home in on the bone marrow, where they establish residence and begin producing healthy blood cells. Bone marrow transplantation is life-saving but challenging. The donor and recipient must be carefully matched to minimize the risk of rejection and other complications. Finding a suitable donor can be difficult, which is why bone marrow donor registries are so important. When a match is found and the transplant is successful, it essentially gives the patient a new blood-forming system. The relationship between bones and blood is so fundamental that it's easy to overlook how extraordinary it is. Your skeleton isn't just a support structure, it's an integral part of your circulatory and immune systems. Without your bones, you wouldn't have blood. Without blood, nothing else in your body could function. The factory inside your bones, working ceaselessly in the darkness of the marrow cavity, is as essential to your life as your heart or lungs. And this factory, like the bones themselves, is constantly monitored and regulated by your body, adjusting its output to meet your moment-to-moment needs. It's a system of such elegance and efficiency that it's hard to fully grasp, even when you understand the mechanisms. Your bones are alive, and nowhere is that more apparent than in the vibrant, busy tissue of the bone marrow. We've explored the internal structure of bone and the blood-forming tissue within it. But now we need to understand how bones connect to each other. After all, a collection of 206 separate bones wouldn't be very useful if they couldn't work together. What gives your skeleton its functionality? What allows you to move, to walk, to reach, to turn your head, is the system of joints that connects bone to bone. A joint, also called an articulation, is any point where two or more bones meet. The human skeleton contains several hundred joints, and they vary dramatically in structure and function. Some joints don't move at all, designed purely for strength and protection. Others allow limited movement. Still, others provide extensive mobility, enabling the complex motions that make humans so dexterous. Joints are classified in two main ways, by structure and by function. Let's start with the structural classification, which is based on what material holds the bones together. Fibrous joints are held together by dense connective tissue with very little or no space between the bones. These are typically immobile or allow only minimal movement. The classic example is the sutures of the skull, the interlocking joints between the cranial bones. If you run your fingers over your scalp, you can sometimes feel the faint ridges where these sutures lie. In infants, The sutures are flexible, allowing the skull bones to overlap slightly during birth, and then expand as the brain grows. In adults, the sutures are rigid, fusing the skull into a solid protective case. Another type of fibrous joint is the syndesmosis, where bones are connected by a ligament or membrane, allowing slightly more movement than a suture. An example is the joint between the tibia and fibula in your lower leg, where a tough membrane holds the two bones together but allows a small amount of give. Cartilaginous joints are held together by cartilage, and they allow limited movement. There are two subtypes. In a synchondrosis, the bones are joined by hyaline cartilage, the smooth, glassy cartilage that covers the ends of most bones. An example is the joint between your first rib and your sternum. These joints provide strength while allowing slight flexibility. The other subtype is a symphysis, where bones are joined by fibrocartilage, a tougher, more fibrous type of cartilage. The classic example is the pubic symphysis, the joint at the front of your pelvis that connects your left and right hip bones. Another example is the joints between your vertebrae, where fibrocartilage discs act as shock absorbers. But the joints that allow the most movement, the ones that make your body truly mobile, are synovial joints. These are the most complex and most numerous joints in your body, and they're engineering marvels. A synovial joint is characterized by having a fluid-filled cavity between the articulating bones. The ends of the bones are covered with articular cartilage, a layer of smooth hyaline cartilage that provides an almost frictionless surface. The entire joint is enclosed in a joint capsule made of dense connective tissue. Inside this capsule, a specialized membrane called the synovial membrane secretes synovial fluid, a viscous liquid that lubricates the joint and nourishes the cartilage. The combination of smooth cartilage surfaces and lubricating fluid makes synovial joints incredibly efficient. When properly functioning, the friction in a synovial joint is lower than that of ice sliding on ice. This allows bones to glide past each other smoothly, enabling movement without damage. Synovial joints are further classified into 6 types based on their shape and the movements they allow. Hinge joints, like your elbow and knee, allow movement in only one plane, like the hinge on a door. You can flex and extend these joints, bringing bones closer together or farther apart, but you can't move them side to side. Pivot joints allow rotation around a single axis. The joint between the atlas and axis, the first 2 vertebrae in your neck, is a pivot joint. It allows you to shake your head no by rotating your skull left and right. Another pivot joint is located in your forearm, allowing your radius to rotate around the ulna, which is what lets you turn your palm up or down. Gliding joints have flat or slightly curved surfaces that slide across each other. These joints allow small, complex movements, but not large ranges of motion. Examples include the joints between the small bones of your wrist and ankle, and the joints between adjacent vertebrae in your spine. Saddle joints are named for their shape. The articulating surface of each bone is concave in one direction and convex in the other, like a saddle. The joint at the base of your thumb is a saddle joint, and it's what gives your thumb its remarkable mobility. You can flex, extend, abduct, adduct, and even slightly rotate your thumb, allowing you to grasp objects and use tools with precision. Condyloid joints, also called ellipsoid joints, allow movement in 2 planes. They're similar to ball and socket joints, but with more restricted motion. Your wrist is a condyloid joint, allowing you to flex and extend your hand, and move it side to side, but not to freely rotate it. Finally, ball and socket joints provide the greatest range of motion. In these joints, the rounded head of one bone fits into a cup-like socket in another bone. Your shoulder and hip are ball and socket joints. They allow flexion, extension, abduction, adduction, rotation, and circumduction, a circular motion that combines several types of movement. Your shoulder, in particular, is the most mobile joint in your body, allowing your arm to move in almost any direction. The trade-off with joints is that mobility comes at the cost of stability. Your shoulder joint is highly mobile, but also prone to dislocation. Your hip joint, with its deep socket and strong surrounding ligaments, is much more stable, but consequently less mobile. Your body balances these competing needs throughout your skeleton, providing mobility where it's needed for function and stability where it's needed for protection and load bearing. Supporting each joint are ligaments, tough bands of connective tissue that connect bone to bone. Ligaments provide stability, preventing excessive or abnormal movements that could damage the joint. Some ligaments are part of the joint capsule itself, while others run alongside or inside the joint. Your knee, for example, has several important ligaments. The medial and lateral collateral ligaments on the sides prevent sideways movement. Inside the joint, the anterior and posterior cruciate ligaments cross each other, preventing the tibia from sliding too far forward or backward relative to the femur. When a ligament is stretched too far, you get a sprain, one of the most common injuries. Mild sprains involve overstretching the ligament fibers. More severe sprains involve partial or complete tears. Unlike bone, which has a robust blood supply and heals relatively quickly, ligaments have limited blood flow, so sprains can take weeks or months to fully heal. Joints are also associated with tendons, which connect muscle to bone. While tendons aren't technically part of the joint itself, they pass across joints and play a crucial role in joint movement. When a muscle contracts, it pulls on its tendon, which pulls on a bone, creating movement at the joint. The combination of muscles, tendons, ligaments, and the joint structure itself determines what movements are possible. Some joints have additional structures for protection or stability. Your knee, for instance, has menisci, C-shaped pads of fibrocartilage that sit between the femur and tibia, providing cushioning and helping distribute weight across the joint surface. Bursae, small fluid-filled sacs, are often found near joints, sitting between bones and tendons to reduce friction. When a bursa becomes inflamed, it's called bursitis, a painful condition that can limit joint movement. Joints are living structures that require maintenance. The articular cartilage that covers bone ends doesn't have a blood supply, so it relies on the diffusion of nutrients from synovial fluid. Movement is essential for keeping joints healthy. When you move a joint, you compress the cartilage, squeezing out waste products. And then, when you relax it, it reabsorbs fresh synovial fluid with nutrients. This is why prolonged immobility can lead to joint stiffness and cartilage degradation. As you age, joints naturally undergo changes. The articular cartilage can wear down, especially in weight-bearing joints, like the hips and knees. The synovial fluid may become less viscous. The joint capsule and ligaments may lose some of their flexibility. In some people, these changes are minimal and cause no problems. In others, they lead to osteoarthritis, a condition where the cartilage breaks down faster than it can be repaired, leading to pain, stiffness, and loss of joint function. Joints can also be affected by inflammatory conditions, like rheumatoid arthritis, where the immune system attacks the synovial membrane, causing inflammation and eventually damaging the joint structures. These conditions remind us that joints, like bones, are living tissues that require proper care and can be subject to disease. The marvel of joints is that they allow a rigid skeleton to become a flexible, functional structure. Without joints, your bones would be a useless pile of rigid rods and plates. With joints, properly designed and maintained, your skeleton becomes a sophisticated mechanical system, capable of the full range of human movement. From the delicate precision of a surgeon's hands to the explosive power of a sprinter's legs. Every time you bend your finger, turn your head, or take a step, you're relying on joints working exactly as they should, providing the perfect balance of mobility and stability. It's a system so reliable that you usually don't think about it until something goes wrong. But understanding how joints work helps you appreciate the engineering behind every movement you make. Now, let's turn our attention to one of the most complex and fascinating parts of the skeleton, the skull. If the skeleton as a whole is a masterpiece of biological engineering, then the skull is perhaps the most intricate component, a structure of such complexity and precision that it took decades of study to fully understand. Your skull contains 22 bones, and in adults, 21 of these are fused together into a seamless whole. The only bone that remains separate is the mandible, your lower jaw. This fusion creates a rigid protective case for your brain, while still maintaining channels for nerves and blood vessels, and creating space for your sense organs. Anatomists divide the skull into two main parts, the cranium or neurocranium, which encases the brain, and the facial skeleton, or viscerocranium, which forms the structure of your face. Let's explore each in turn. The cranium consists of 8 bones. At the front is the frontal bone, which forms your forehead and the upper parts of your eye sockets. Behind the frontal bone, forming the top and sides of your skull, are 2 parietal bones, one on each side. These large curved bones meet at the top of your head along the sagittal suture, one of the major skull sutures. At the back of your skull is the occipital bone, which forms the base of the cranium and contains the foramen magnum, the large opening through which your spinal cord passes to connect with your brain. On each side of your skull, forming the lower portions of the sides and part of the base, are the temporal bones. Each temporal bone contains the delicate structures of the inner ear and forms part of the jaw joint. 2 bones of the cranium are less visible from the outside, but are crucial to the skull structure. The sphenoid bone sits at the base of the skull, right behind your eyes. It's shaped somewhat like a bat with outstretched wings and forms part of the floor of the cranial cavity, part of the sides of the skull, and part of the back of the eye sockets. The ethmoid bone is located between your eyes, behind the bridge of your nose. It forms part of the walls of the eye sockets and much of the nasal cavity, including the superior and middle nasal conchae, the curved bones inside your nose that warm and humidify the air you breathe. The sutures connecting these cranial bones are more than just joints. In a way, they're also growth zones. In infants and young children, the sutures contain fibrous tissue that allows the bones to grow and expand as the brain grows. The largest gaps between skull bones in infants are called fontanelles, the soft spots that parents are often warned to protect. The largest and most well-known is the anterior fontanelle at the top front of the skull, where the frontal bone meets the two parietal bones. This doesn't fully close until the child is about 18 months old. A smaller posterior fontanelle at the back of the skull usually closes by 2 to 3 months of age. As the child grows and the fontanelles close, the sutures remain visible and identifiable. The coronal suture runs across the top of the head from side to side, where the frontal bone meets the parietal bones. The sagittal suture runs from front to back along the midline where the two parietal bones meet. The lambdoid suture runs across the back of the skull, where the occipital bone meets the parietal bones. These sutures don't fully fuse until adulthood, and even then, they remain visible on skulls as distinctive wavy lines. The base of the skull, the cranial floor, is divided into 3 regions called fossae. The anterior cranial fossa, which supports the frontal lobes of the brain. The middle cranial fossa, which supports the temporal lobes. And the posterior cranial fossa, which supports the cerebellum and brainstem. The floor of the skull is perforated by numerous foramina, openings through which nerves and blood vessels pass. The largest is the foramen magnum in the occipital bone, but there are many others. The optic foramina for the optic nerves, the internal acoustic metases for the auditory nerves, the jugular foramina for the major veins draining brain, and many more. Now, let's turn to the facial skeleton. This consists of 14 bones, arranged in a complex 3-dimensional puzzle that creates the structure of your face. At the center are the 2 maxillae, or maxillary bones, which form your upper jaw. These bones hold your upper teeth, form the front part of the roof of your mouth, and make up much of the floor and sides of your nose and the floor of your eye sockets. The maxillae meet at the midline in a nearly invisible joint. The 2 zygomatic bones, one on each side, form your cheekbones and the outer edges of your eye sockets. These prominent bones give your face much of its contour and protect the sides of your eyes. The 2 nasal bones, small and rectangular, form the bridge of your nose. These are the bones that break in a broken nose injury. Below and behind them, the single vomer bone forms the lower part of the nasal septum, the wall dividing your nasal cavity into left and right halves. Inside your nasal cavity are 2 pairs of delicate, scroll-like bones called the nasal conchae. The superior and middle conchae are actually parts of the ethmoid bone, as mentioned earlier, but the inferior nasal conchae are separate bones. These conchae increase the surface area inside your nose, helping to warm, humidify, and filter the air you breathe. At the back of your mouth are 2 L-shaped palatine bones, one on each side. These form the posterior part of the hard palate, the roof of your mouth, and contribute to the floor of your nasal cavity and the back of your eye sockets. The 2 lacrimal bones, the smallest bones in your skull, are located at the inner corners of your eye sockets. Each contains a groove that helps form the nasolacrimal canal, the channel through which your tears drain from your eyes into your nasal cavity. This is why your nose runs when you cry. Finally, we come to the mandible, the only movable bone in your skull. The mandible forms your lower jaw and holds your lower teeth. It's a horseshoe-shaped bone with a horizontal body and 2 vertical branches called rami. At the top of each, ramus is a rounded condyle that fits into a socket in the temporal bone, forming the temporomandibular joint, or TMJ. This joint allows you to open and close your mouth, move your jaw from side to side, and even thrust it forward and backward. These movements are essential for chewing, speaking, and facial expression. The skull also contains spaces within the bones called paranasal sinuses. These are air-filled cavities lined with mucous membranes, located in the frontal bone, the maxillae, the ethmoid bone, and the sphenoid bone. The sinuses lighten the weight of the skull and act as resonating chambers that give your voice its particular quality. When your sinuses become inflamed and fill with mucus, as happens with a cold or sinus infection, you feel the characteristic pressure and pain, and your voice sounds different because the resonance has changed. The complexity of the skull serves multiple functions. Most obviously, it protects your brain, one of your most vital and vulnerable organs. The cranial bones are thick enough to provide substantial protection from impacts, yet they're not so thick that your head becomes impossibly heavy. The skull also protects your eyes, housing them in bony sockets that shield them from all sides except the front. It provides a framework for your facial muscles, the muscles responsible for facial expressions and chewing. It creates the resonating chambers for your voice, and it houses the organs of your special senses, your eyes, your ears, your olfactory organs in the nasal cavity, and your taste buds in the mouth. The skull also reveals a great deal about human evolution. The size and shape of the cranium reflect the large human brain. The position of the foramen magnum, directly underneath the skull rather than at the back, reflects our upright posture. The structure of the face, with a relatively flat profile and reduced jaw muscles compared to other primates, is associated with our evolution toward a diet that required less powerful chewing and a face adapted for complex speech. Understanding the skull helps us appreciate the sophistication of skeletal structure. Every curve, every opening, every ridge serves a purpose. The skull isn't a simple box. It's a meticulously designed structure that balances protection with weight, strength with flexibility, and form with function. Like the rest of the skeleton, it's a testament to millions of years of evolution and development. We've explored the structure of bone, the organization of the skeleton, how bones grow, what they contain, how they connect, and the complexity of the skull. Now, we need to understand one more crucial concept. Bone is not a static structure. Even after you've stopped growing, your bones are constantly being remodeled, rebuilt, and reshaped. This process continues throughout your entire life, and it's essential for maintaining skeletal health. Bone remodeling is a carefully coordinated process involving the removal of old bone tissue and its replacement with new bone tissue. It serves several critical functions. First, it repairs microscopic damage that accumulates in bones from normal daily stress. Every time you walk, run, or lift something, tiny cracks form in your bone matrix. If these weren't repaired, they would accumulate over time and eventually lead to fractures. Second, remodeling allows bones to adapt their structure in response to the forces acting on them, becoming stronger where stress is greatest. Third, remodeling helps regulate calcium levels in your bloodstream by releasing or absorbing calcium from bone. The remodeling process occurs in discrete locations called basic multicellular units, or BMUs. Each BMU is a temporary structure consisting of a team of osteoclasts followed by a team of osteoblasts, working together in a carefully choreographed sequence. The cycle begins when signals from osteocytes or other sources indicate that a particular area of bone needs to be remodeled. These signals might result from accumulated microscopic damage, from changes in mechanical loading, or from hormonal influences. In response, osteoclasts are recruited to the site. These large, multinucleated cells attach themselves to the bone surface and begin the resorption phase. Osteoclasts break down bone through a remarkably effective process. They create a sealed compartment against the bone surface and secrete hydrogen ions into this space, creating an extremely acidic environment that dissolves the mineral component of the bone. They also secrete enzymes that digest the collagen and other organic components. The result is that the bone surface is literally eaten away, creating a depression or cavity. This resorption phase lasts about 2 to 3 weeks. During this time, the osteoclasts dig out a tunnel through compact bone, or create a pit on a trabecular bone surface. The depth and extent of resorption are precisely controlled. Once the osteoclasts have removed the appropriate amount of bone, they undergo apoptosis, programmed cell death, and disappear. Following the resorption phase is a brief reversal phase, during which the bone surface is prepared for new bone formation. Mononuclear cells appear and smooth the resorption cavity, removing any remaining debris and preparing the surface for osteoblasts. Then comes the formation phase. Osteoblasts arrive at the site and begin laying down osteoid, the unmineralized organic matrix of bone. They fill in the cavity that the osteoclasts created, working systematically from the edges toward the center if it's a tunnel, or from the bottom upward if it's a pit. The osteoblasts work for several months, gradually filling in the resorbed space. As the osteoid is deposited, it begins to mineralize. Calcium and phosphate ions from the bloodstream crystallize within the organic matrix, hardening it into mature bone tissue. Some of the osteoblasts become trapped in the osteoid they've created and transform into osteocytes, the mature bone cells that will monitor this region of bone for future stress and damage. The entire remodeling cycle, from initiation to completion, takes about 3 to 6 months for a single BMU. But thousands of these cycles are occurring simultaneously at different locations throughout your skeleton. It's estimated that about 5 to 10% of your entire skeleton is being remodeled at any given time. This means that over the course of several years, your entire skeleton is essentially replaced, although the overall shape and structure remain the same. The rate and pattern of bone remodeling are influenced by numerous factors. Mechanical stress is crucial. Bones respond to the loads placed on them by becoming stronger. This is known as Wolff's Law, after the 19th century anatomist Julius Wolff, who first described it. When you exercise, especially with weight-bearing, activities or resistance training, you create microscopic damage in your bones. This stimulates the remodeling process, and the new bone that's laid down is slightly stronger and denser than the old bone. Over time, with consistent loading, bones become significantly stronger. Conversely, when bones aren't loaded, they lose mass. This is why bed rest and immobility can lead to rapid bone loss. It's also why astronauts in zero gravity experience significant bone loss despite exercise regimens. Without the constant load of gravity, the stimulus for bone maintenance is reduced, and bone resorption outpaces bone formation. Hormones play a major role in regulating bone remodeling. Parathyroid hormone, secreted by the parathyroid glands in your neck, increases bone resorption, releasing calcium into the bloodstream when blood calcium levels drop. Calcitonin, secreted by the thyroid gland, does the opposite. inhibiting bone resorption when blood calcium is high. Vitamin D, which is actually a hormone despite its name, is essential for calcium absorption from the intestines and for proper bone mineralization. Sex hormones, particularly estrogen, are crucial for maintaining bone mass. Estrogen inhibits bone resorption, helping maintain the balance between breakdown and formation. This is why menopause, which causes a sharp drop in estrogen levels, often leads to accelerated bone loss in women. Men have higher levels of testosterone, which is converted to estrogen in their bodies and serves a similar protective role, though they typically don't experience as sharp a decline with age as women do. Growth hormone and thyroid hormones also influence bone remodeling. Growth hormone stimulates both bone formation and resorption, increasing overall bone turnover. Thyroid hormones affect the rate of remodeling and are essential for normal skeletal development. In healthy, young and middle-aged adults, bone formation and resorption are balanced, resulting in stable bone mass. But this balance can be disrupted in various ways. In childhood and adolescence, formation exceeds resorption, leading to growth in bone mass. Peak bone mass, the maximum amount of bone you'll ever have, is typically achieved in your 20s or early 30s. After that, and especially after age 40, resorption gradually begins to outpace formation, leading to a slow, progressive loss of bone mass. This age-related bone loss is normal to some extent, but in some people, it becomes excessive, leading to osteoporosis, a condition we'll discuss in the next section. The key point is that bone remodeling continues throughout life, and the balance between formation and resorption determines whether your bones are getting stronger, staying stable, or becoming weaker. The sophistication of the bone remodeling system is truly remarkable. Your body is constantly monitoring your skeleton, detecting damage, responding to mechanical forces, regulating mineral levels, and coordinating the activities of millions of cells to maintain bone health. All of this happens without your conscious awareness or effort. You don't think about remodeling your bones any more than you think about digesting your food or filtering your blood. Your body simply does it, continuously and efficiently for as long as you live. Understanding bone remodeling helps explain why nutrition and exercise are so important for skeletal health. The building blocks for bone, calcium and phosphorus and vitamin D must come from your diet. The stimulus for bone maintenance comes from mechanical loading. Together, proper nutrition and regular weight-bearing exercise help ensure that the remodeling process maintains or even increases bone strength rather than allowing it to deteriorate. It also helps us understand why certain medications can affect bone health. Corticosteroids, commonly prescribed for inflammatory conditions, can disrupt the balance of bone remodeling, favoring resorption over formation and leading to bone loss. Other medications can have the opposite effect, slowing resorption and helping preserve bone mass. The delicate balance of bone remodeling is influenced by many factors, and understanding these influences is key to maintaining skeletal health throughout life. No discussion of bone would be complete without addressing what happens when things go wrong. Bones, for all their strength and resilience, are subject to various diseases and disorders. Some of these are relatively minor and easily treated. Others are serious, chronic conditions that can significantly impact quality of life. The most common bone disease is osteoporosis, a condition characterized by low bone mass and deterioration of bone microarchitecture, leading to increased fracture risk. The name literally means porous bones, and that's an accurate description. In osteoporosis, the normal balance between bone resorption and formation is disrupted, with resorption occurring faster than formation can keep up. Over time, bones become thinner and weaker. Osteoporosis is often called a silent disease because it typically has no symptoms until a fracture occurs. The most common osteoporotic fractures are of the hip, spine, and wrist, though any bone can be affected. Hip fractures are particularly serious in elderly individuals and are associated with significant disability and mortality. Vertebral fractures can cause chronic pain, loss of height, and a stooped posture. The primary cause of osteoporosis is aging, particularly the decline in sex hormones that occurs with menopause in women and, more gradually, in older men. However, numerous other factors contribute, including genetics, inadequate calcium and vitamin D intake, lack of weight-bearing exercise, smoking, excessive alcohol consumption, and certain medications. Osteoporosis is diagnosed using a test called dual energy X-ray absorptiometry, or DEXA scan, which measures bone mineral density. Treatment typically includes calcium and vitamin D supplementation, weight-bearing exercise, and often medications that either slow bone resorption or stimulate bone formation. Fall prevention strategies are also crucial, since the primary danger of osteoporosis is fractures resulting from falls. Related to osteoporosis is osteomalacia, a condition characterized by softening of the bones due to inadequate mineralization. While osteoporosis involves loss of both mineral and organic matrix, osteomalacia specifically involves a deficiency in the mineral component while the organic matrix remains. The result is bone that's softer and more prone to deformities and fractures. The most common cause of osteomalacia is severe vitamin D deficiency, which impairs calcium absorption and bone mineralization. In children, this condition is called rickets and can lead to skeletal deformities like bowed legs because the soft bones bend under the child's weight. In adults, osteomalacia typically causes bone pain, muscle weakness, and increased fracture risk. Treatment involves addressing the underlying cause, usually with high doses of vitamin D and sometimes calcium supplementation. Another significant bone disease is Paget's disease, a condition in which the normal bone remodeling process becomes disorganized and accelerated. In affected bones, excessive bone resorption is followed by excessive but disorganized bone formation, resulting in bone that's structurally abnormal. The new bone is often larger and less organized than normal bone, with a mosaic pattern of collagen fibers rather than the normal parallel arrangement. Paget's disease most commonly affects the pelvis, spine, skull, and long bones of the legs. It can cause bone pain, deformities, and pathological fractures. If it affects the skull, it can cause headaches and, rarely, hearing loss if the abnormal bone growth affects the middle ear. Treatment typically involves medications called bisphosphonates that slow bone remodeling, along with pain management, and, in some cases, surgical correction of deformities. Bone infections, called osteomyelitis, can occur when bacteria, or, less commonly, fungi invade bone tissue. This can happen through the bloodstream from a nearby infection, or as a result of trauma that exposes bone to the outside environment. Osteomyelitis is serious because bone, once infected, is difficult to treat. The infection can become chronic, causing ongoing pain, bone destruction, and sometimes requiring surgical removal of dead bone tissue. Treatment typically involves long courses of antibiotics and sometimes surgery. Bone tumors can be benign or malignant. Benign bone tumors, while they can cause problems by growing and weakening bone, don't spread to other parts of the body. Malignant bone tumors, or bone cancers, can be primary, meaning they originate in bone tissue, or metastatic, meaning they spread to bone from cancer elsewhere in the body. Osteosarcoma is the most common primary bone cancer, typically affecting children and young adults. Treatment usually involves surgery to remove the tumor and chemotherapy. Genetic disorders can affect bone development and maintenance. Osteogenesis imperfecta, often called brittle bone disease, is a group of genetic disorders that affect collagen production, resulting in bones that are abnormally fragile and prone to fractures. The severity varies widely from mild forms that cause slightly increased fracture risk to severe forms that cause numerous fractures even from minimal trauma. Rickets, which we mentioned earlier, can have genetic as well as nutritional causes. Certain rare genetic disorders affect vitamin D metabolism or phosphate regulation, leading to rickets despite adequate dietary intake of these nutrients. These forms of rickets require specialized treatment targeting the underlying genetic defect. Fractures, while not diseases per se, are common bone injuries that deserve mention. A fracture is simply a break in a bone, but fractures vary enormously in severity. Some are tiny hairline cracks that heal with minimal treatment. Others are complete breaks, where the bone is severed into 2 or more pieces. Compound fractures, where the broken bone punctures through the skin, are particularly serious because they create a high risk of infection. The healing process for a fracture is remarkable. Within hours of the break, blood clots around the fracture site and immune cells begin cleaning up damaged tissue. Within days, specialized cells called fibroblasts move into the area and begin laying down a fibrous callus, a temporary bridge of fibrous tissue. Osteoblasts soon follow, converting this fibrous callus into a bony callus of immature bone. Over weeks to months, this bony callus is remodeled and replaced with mature bone, eventually restoring the bone to nearly its original strength and structure. Most fractures heal completely with proper treatment, which usually involves immobilization to keep the bone ends aligned while healing occurs. Some fractures require surgery to realign the bones and hold them in place with plates, screws, or rods. The healing time varies depending on the bone involved, the severity of the fracture, and individual factors like age and overall health. Understanding bone diseases and injuries helps us appreciate why taking care of our bones is so important. While many factors affecting bone health are beyond our control, genetics and age in particular, many others are within our power to influence. Adequate nutrition, especially calcium and vitamin D intake, is essential. Weight-bearing exercise, which stimulates bone remodeling and strengthening, is equally important. Avoiding smoking and excessive alcohol consumption helps protect bone health. For those at high risk of osteoporosis, regular screening and, if needed, preventive treatment can help maintain bone strength and reduce fracture risk. The skeleton is strong and resilient, but it's not invulnerable. Like every other system in your body, it requires care and attention to function optimally throughout your life. The good news is that bones are remarkably responsive to the care you give them. Exercise makes them stronger. Proper nutrition supports their structure. And when damage occurs, they have an impressive capacity to heal and rebuild. As we come to the end of our journey through the skeleton, it's worth taking a moment to reflect on what we've discovered. Your bones are far more than a framework that holds you upright. They're a dynamic, living system, constantly active, constantly changing, constantly working to keep you healthy. Inside this system, blood cells are born every second, replacing old cells and giving you the oxygen-carrying capacity, immune protection, and clotting ability you need to survive. Minerals are stored and released, maintaining the precise balance of calcium in your blood that your nerves and muscles depend on. Forces are absorbed and redistributed, protecting your internal organs and allowing you to move through the world. And through it all, your skeleton adapts. It responds to the demands you place on it, becoming stronger where you need strength, reshaping itself when necessary, repairing damage, and maintaining its integrity year after year. When you stand up from your chair after listening to this, your skeleton will support your weight without you giving it a thought. When you walk to wherever you're going next, your joints will bend and flex in perfect coordination. When you reach for something, your bones will provide the leverage your muscles need to move your arm. All of this happens automatically, silently, efficiently. Your skeleton is a gift from evolution, refined over millions of years. It's a gift from your parents, encoded in your genes. It's a gift from your own body, which has been building and maintaining this structure since before you were born, and will continue doing so for as long as you live. Understanding your bones, truly understanding them, helps you appreciate the extraordinary complexity and capability of your own body. Every breath you take depends on ribs that move. Every step you take depends on a skeleton that supports you. Every moment of consciousness depends on a skull that protects your brain. So, perhaps tonight, as you drift off to sleep, you can think about the quiet work happening inside you. Think about the osteoblasts building new bone, the osteoclasts removing old bone, the bone marrow producing millions of new blood cells. Think about the remarkable structure that lies beneath your skin, holding you together, keeping you alive, allowing you to experience everything that makes life worth living. Your skeleton is alive, and it's one of the most beautiful, sophisticated, and essential parts of who you are. Thank you for joining us on Bedtime Biology tonight. If this gentle exploration has helped you relax or taught you something new, please consider liking this video and subscribing to our channel. Let us know in the comments where you're listening from and what topics you'd like us to explore next. Sweet dreams, and remember, even as you sleep, your bones are working tirelessly to keep you healthy and strong.